Hi, my name is Ravi Vij. I'm from My Cancer Haven. And today, once again, in our Conversation with Cancer Experts series, we have Dr. Binod Dhakal with us. He's Associate Professor of Medicine, a well-respected and established authority in the field of multiple myeloma, been doing a lot of novel work, publications, and now he's going to talk to us about cemsidomide, which is data he presented at the recently concluded International Myeloma Society meeting in Canada, Toronto. So welcome, Binod.
Thank you, Ravi. Thank you for having me.
So we're going to talk about this phase 1 study of cemsidomide. And before we get into the data, could you lay the groundwork for our audience about what is cemsidomide?
Definitely. So the cemsidomide is what we call as degraders. They are the novel protein degraders, and if you look at it, it's a class of drugs like lenalidomide, pomalidomide, in that kind of a subject area, but it's a more potent degrader of transcription factor proteins that is very active in myeloma, the IKGF1 and 3. So I would say that this is a very novel mechanism, and there are a few other in clinical development. There is nothing has been approved yet, and when you compare to this novel, the protein degraders, I mean, this seems to be more potent when you compare to the other ones. They bind to the cereblon, as shown here in the diagram, and they cause the degradation of this IKGF1 and 3. And they have very high affinity to even myeloma cells with a low cereblon level. Sometimes you can have low cereblon and these degraders may not be able to bind it, but in this case, this is able to bind that even with the low cereblon, and they can do the sustained degradation. I mean, we'll talk about the data a little bit later. We're looking at the IKGF1 and 3 from the peripheral blood of the patients, and we can see they cause sustained degradation of that. In addition to the degrading the protein and killing the myeloma cells, it also is an immunomodulatory drug in the sense that it activates the immune system, it activates the T cells, promotes the secretion of cytokines and prevent the T cell exhaustion. And so that is something that helps in the anti-myeloma activity. One of the common class effect of these drugs is on-target neutropenia, because it disrupts this IKGF1/3 and the hematopoietic stem cell system, and that helps us to understand how to dose this in the clinical setting.
So we have been hearing a little bit about another class of drugs that is also in development, CELMoDs. Is there a difference between protein degraders, CELMoDs, or are these just interchangeable?
It's a similar class of drugs. So that's why when I mentioned that this class of drugs are in clinical development, one of them is CELMoDs and one of them is this. It is more or less similar mechanism of action, but it's supposed to be more potent than the CELMoDs in development, and also bind to even have more affinity to low cereblon levels.
So can you tell us about the study that you presented? What was the study design?
Yeah, so initially the cemsidomide was studied as a monotherapy in patients with relapsed refractory multiple myeloma. Then later on, this study which I presented is a combination of the dexamethasone, is a phase 1/2 clinical trial with the dose escalation expansion. Those escalations started with a 50 microgram 3 times a week, 14 days on and 14 days off. And then with the Bayesian logistic regression that was up, that was escalated. And then as shown here, it was escalated to the maximum tolerated dose or maximum assessed dose. And the patients that were included were patients with a triple class refractory disease and at least 3 prior lines of therapy. And they needed to have, both lenalidomide and pomalidomide. And, they can't just have one IMiD. They just need to have both the IMiDs because you want to make sure that this works in the patient has already seen both of these IMiDs, and then anti-CD30 antibody, and as refractory to the last line of therapy. Here, the schedule is 14 days on, 14 days off with dexamethasone. This is because of the reason that 14 days off will help that on-target neutropenia to reverse and get back to normal. So this is the phase 1/2 study. For phase 1, we wanted to assess the safety and tolerability and determine the maximum tolerated dose, the recommended phase 2 dose. And the other endpoints are to assess the pharmacokinetics and the anti-tumor activity of this compound.
So what was the demographics of the patients accrued?
Yeah, so the median age was 67. The total of 72 patients were enrolled. That we present the data. Pretty heavily treated patients. If you look at the median prior lines of therapy, there are 7, and most of these patients are mainly 3 or 4 prior lines of therapy. 81% of patients had more than 5 prior lines of therapy. And if you look at the presence of extramedullary disease, 1/3 of the patients have extramedullary disease. But more importantly, these patients, almost 75% of patients had either CAR T or T cell engager therapy. So very heavily treated patients in that sense. And if you look at the BCMA, almost 75% of prior BCMA therapy for those who had either CAR T or bispecific. 47 had GPRC5D therapy, and almost 80% of patients were pentaclast refractory. So if you just look at the patient profile, this is something that people are using, or we have used in patients who have limited options left.
And so how was it tolerated?
So this is the safety data summary. You look at the treatment emergent adverse events. I mean, at all those levels, there were some form of treatment emergent adverse events seen. But if you look at the treatment emergent adverse events related to Cemsidomide, this seems to be pretty well tolerated, 70-75%. And the grade 3 treatment emergent adverse events, related to Cemsidomide is about 60%. And very few patients discontinued, and very few patients had to have dose reduction because of that. There was 4 DLTs were observed. 1 patient at 62.5 microgram, and 3 patients at 100 microgram. Mainly the DLTs were the dose-limiting neutropenia, but at 100 microgram, we also saw the AST, ALT elevation, and febrile neutropenia and pneumonia.
And so any specific toxicities that...
I think the most important thing is the neutropenia. As you can see, Ravi, that the grade 3-4 neutropenia, the overall neutropenia is 61%, and grade 3 and 4 is about, if you just look at the grade 4 neutropenia, is 33%. Now, why it is important is if you look at the other cell morphs in development, then you are seeing a little bit higher rates of grade 4 neutropenia. So we are seeing neutropenia, but a little bit lower grade. In terms of infections, there is very few grade 4 infections. There is mainly there are grade 1s and grade 2. Otherwise, the other cytopenia, as you can see, is as expected with this drug. One of the things that also we want to highlight is that GCS of support was not allowed during the dose escalation part. But once we started doing the dose expansion in that recommended that dose level, the GCS use was allowed liberally, and that could be one of the reasons we are still seeing that grade 3 neutropenia or grade 4 neutropenia, because the GCS was not allowed during the dose escalation. So when this therapy goes into expansion or to the later stages, I think that's the key, that we can use the GCSF more liberally, and you may not be able to see that higher rates of neutropenia.
And let's shift to the efficacy. So
what we want to look at is looking initially at the DFLC reduction, because of course the phase 1 we want to look at the safety, but we also look at some preliminary anti-tumor activity. You can see that the DFLC reduction was achieved in more than 50% of patients, at least more than 50% DFLC reduction. And this seems to be, this is active. This compound is active in these heavily treated patients.
And what about responses?
So this is the, so based on what we saw in the DFLC reduction, you can see that it translating into MWG assessed responses. The overall responses, as you can see, clearly there's a dose-dependent responses. For example, at 50 microgram, only 17% responded, and then you go to 100 microgram, which is the maximum dose that we have tested so far. 14 days on, 14 days off, you have 50% response rate, and some CR, mainly VGPR and PR. And if you look at the overall patient population, the overall response is 34%. So I would say, this is encouraging activity for the type of patients that were treated with the median prior lines of therapy of 7, and almost 75% had the prior T-cell engager therapy. If you just look at the patients on 100 microgram, that is 50%. So that is really encouraging. And when you break down into the patients who had prior BCMA-directed therapy, their response is also about 50%. So overall, I think this is a very encouraging activity, and would like to see that in patients, larger scale, larger cohort of the patients.
And how durable are these?
So the durability of responses at 100 microgram, the follow-up is still short. So that is not really captured that, but the median PFS is 3.7 months and median duration of response is 9.3 months. So I think as an oral pill of 14 days on and 14 days off, and in the top type of the patient that is treated, I think even this by data by itself is very kind of encouraging to be tested in the in the larger cohort of the patient in the phase 2.
So what's the takeaway?
So the takeaway is that cemsidomide is a novel degrader or monodac degrader that is 14 days on, 14 days off to dex oral. That demonstrated like this is safe at all dose levels, and response rate of overall response of 34%, but at highest dose level is 50% in a very heavily treated patients, with 75% of patients have prior T cell based therapies and prior CAR T. And we didn't saw that slide, but we also saw that it induces potent IKGF1/3 degradation. In addition, we also looked at the CD8 T cell activation in these patients, and they were pretty robust activation of CD8 T cells, so underscoring the immune stimulating activity of this compound. Now, what we're doing right now is we're testing this in the phase 2 in a 4+ line patient, with the dexamethasone 14 days off, 14 days off. And then also in combination with the T cell engager therapy, because of its immunostimulating activity, we're testing that in with the bispecific antibody in late relapse patient population. So it will be exciting to see how this drug by itself, as well as in combination, would fare in this heavily treated patient population.
So this is going to ultimately require a phase 3 study for licensure, or is there a chance that one could see it based on an accelerated?
There's a chance we could see the from the phase 2 4th-line plus, we can see the accelerated approval, but I think that is also based on the feedback from the agency and so on and so forth. So.
Well, again, congratulations on a superb presentation at the IMS meeting, and thank you for taking the time to talk to us about this exciting new compound. And I'm sure I'll reach out to you again as you get more data. You're leading some of the trials that are going to follow. So once again, looking forward to you having great success with these efforts.
Thank you, Ravi. Thank you for having me.
Thank you.